Welcome back. In the chapter of health programs in India, we were discussing about the National Vector-Borne Disease Control Program, which is an umbrella program for the prevention and control of six vector-borne diseases, namely malaria, filariasis, dengue, Japanese encephalitis, Kala Azar, and chikungunya. So this is an umbrella program. So now guys, in this we were discussing mainly about malaria, wherein we have already dealt about the parameters, the milestones, goals and objectives. Now in the part 2 we will be discussing about the milestones and targets. So what are the milestones and targets which the Malaria Control Program is having? Starting with, by the year 2020, all the 15 states or the union territories under the category 1 in 2014 have to completely interrupt the malaria transmission and achieve the zero indigenous cases and deaths due to malaria. Now, before understanding this, let us quickly brush through the categories what we discussed in the previous video. If they are in category 0, it means that the states or union territories have zero indigenous cases of malaria. If they are in category 1, they have API less than 1. If they are in category 2, they have API less than 1 in states, but some of the districts will have API more than 1. That is the pre-elimination phase. Lastly, we have category 3, the intensified control phase, where the API will be more than or equal to 1. Fine. Now starting with 2020, what was the target or the milestone by 2020? They want all the states in 2014, all the states which are falling under the category 1, okay, have to completely interrupt this malaria transmission and achieve zero indigenous cases and deaths due to malaria. So category 1 is what guys? API will be less than 1 in them. So category 1, they are in the elimination phase. All the states who are in the elimination phase, that is API less than 1, they have to achieve zero indigenous cases by the year of 2020. Next, all category 2 states should enter the category 1. Those states in 2014, okay, they are considering the year 2014, presently 2014. By the year, okay, by the year 2020 comes, all the category 1 states should have the zero indigenous deaths, which is nothing but they have to enter category 0. They mean that. Next, the category 2 should enter category 1. The 5 category 3 states, okay, should enter the category 2 states. Now, when we studied the category 3 states, we saw that there were 10 states which were falling under this category. So out of these 10 states, which are falling under the category 3, the 5 states, okay, the 5 states have to enter the category 2, and the remaining 5 states should reduce the disease burden. Okay, they have to reduce the disease burden. Estimated malaria burden at the national level should be reduced by 15 to 20% as compared to the year 2014. The disease burden by the year 2020 should reduce by 15 to 20%. Simple, guys. So without saying, let us try to recall what did we study now. The milestones and targets. We are studying about the milestones and targets. In the milestones and targets, we are beginning with the year 2020. By the year 2020, what are all the targets? First thing, now we are comparing in the year 2014, and our target is by the end of 2020. The first thing is all the states, that is about 15 states which are present in the category 1. 15 states in category 1 should have zero indigenous cases. They should interrupt malaria transmission and have zero indigenous cases. And the states, the 11 states which are under the category 2 in 2014, they have to enter into category 1 by the end of 2020. Third thing, the category 3 have total 10 states, right? The 10 states in category 3, the first 5 states should enter into category 2. The remaining 5 states, the disease burden has to come down. And lastly, the disease burden should be come down by 15 to 20%. I hope it is clear. We have revised it. So you can see here, by the 2020, category 1 should have zero indigenous cases and interrupt the malaria transmission. Next, category 2 should enter category 1. Category 3 should enter category 2. Total 10 states are there. So then the category 3 should reduce, 5 states should reduce the disease burden. First 5 and the other 5. Next, the malaria burden at the national level should be reduced by 15 to 20%. So this clears. So you can just see here, the category 0, no state, okay, 0 states. And then category 1, we have 15 states. Category 2, we have 11 states. And lastly, category 3, we have 10 states. So now this was the target for the year 2020. Moving on, we have that continuation of the 2020, the 2022, the milestones and targets next by the year of 2022. All the states and union territories under category 1 and 2, they have to interrupt the malaria transmission and achieve zero indigenous cases and deaths due to malaria. So by the year 2022, first point what guys? The states which are under the category 1 and the category 2, category 1 and 2 should have zero indigenous cases and deaths due to malaria. Next, 5 category 3 states to enter category 2 and other 5 to enter category 1. Previously we saw that the category 3 has total 10 states. Out of the 10 states, again the division 5 and 5, the first 5 have to enter category 2 and the other 5 have to enter the category 1. Next, the estimated malaria burden should reduce by 30 to 35%. Clear guys? Estimated malaria burden to reduce by 30 to 35%. So now let us revise this category by the year 2022. Now we are starting by the year 2022. In the first place, all the states which are belonging to category 1 and 2 should have zero indigenous cases. They should prevent the transmission of the malaria, interrupt the transmission of the malaria. Second thing, the category 3 which are having total 10 states, the 5 states should enter into category 2 and the remaining 5 states, they have to enter into the category 1. Simple. Next, and the malaria burden should come down by 30 to 35%. Okay. Previously we saw 15 to 20%. Here 30 to 35. Okay. Double. 15, here 30. 15 to 20, 30 to 35. Okay. 15 and 30. Fine. Moving on to the next milestone by the year 2024. What are they expecting? What is the target kept for the year 2024? All the states and union territories and their districts to reduce the API less than 1 per 1,000 population at risk. They should sustain the zero deaths due to malaria and they have to establish a functional malaria surveillance to track, investigate and respond to the cases. So they said that all the states and the union territories and also all the districts have to reduce less than 1 case per 1,000 population and also set up a surveillance functional malaria surveillance to track, to investigate and respond to the cases so that they can sustain zero deaths due to malaria. The second point, the 31 states or the union territories to interrupt the transmission of malaria and zero indigenous cases and deaths due to malaria. All the 31 states, okay, they have to interrupt the transmission of the malaria and attain zero indigenous cases or deaths due to malaria. Lastly, the 5 states in the category 3, which were under the category 3 in 2014, they have to enter into the elimination phase, which is nothing but the category 1. Okay, simple, guys. So by the year 2014, let us try to revise. Okay, let us try to recall what we studied. By the year 2024, what are they expecting? In the first place, all the 31 states. Before that, all the states, union territories. Okay, guys. By the year 2024, first point, all the states, okay, all the states, union territories, districts, everything, they should have API less than 1 per 1000 population. Okay, per 1000 population, API should be less than 1 per 1000 population in order to sustain zero indigenous cases. The second thing, all the 31 states should interrupt malaria and attain zero indigenous cases. Third point, we saw that the 5 states in the category 3 should enter the elimination phase, which is nothing but the category 1. Clear? I hope it is clear. The milestones by 2024 we revised. Next, moving on, by the year 2027, the indigenous transmission has to be interrupted. Entire country should have no indigenous cases and no deaths due to malaria. So very simple, indigenous transmission has to be interrupted and entire country should have no cases, which is nothing but zero indigenous cases or deaths due to malaria. Simple. Transmission should be interrupted and zero indigenous cases and deaths due to malaria. Zero or no deaths due to malaria. Moving on, by the year 2030, the entire country, by the year 2030, the entire country should sustain a status of zero indigenous cases and deaths due to malaria for a period of 3 consecutive years. And India to initiate the processes for the certification of malaria elimination status. So we see that very important, the entire country should have zero indigenous cases or deaths due to malaria for a period of 3 consecutive years. You can remember 2030, 3 consecutive years. They should have no cases of malaria, no deaths due to malaria. 2027, indigenous transmission should be avoided and zero indigenous cases or deaths due to malaria. Simple. Okay, guys, this was all about the milestones. So it seems very tough, okay, at the first time, but then if we read it or repeat it twice and try to recall it, we will be able to do it. So let us quickly recall. Can you guys recall? By 2020, what are all the years? First we will recall the years. 2020, 2024, 2027 and 2030, right? These are the 4 years where you're going to write about the important milestones and the targets. We also have 2016. About 2016, the states, they have to include this malaria elimination in their policies and planning. So this is not much important. You remember these 4, okay? Only thing, in 2016, they have to introduce the malaria elimination policies and planning, okay? Fine. Now let us begin with 2020. Quick revision, okay? This should be very quick. By the year 2020, you guys have to tell me. What did we see? First thing, all the 15 states which are under the category 1 have to achieve zero indigenous cases and deaths due to malaria. Next, this category 2 has to enter into category 1. And then we came to category 3. 5 states have to enter into category 2 and the remaining 5 should enter into category 1. And the disease burden, what did I say? 15 to 20%. Simple. Category 1 should enter 0. See, the category 1 to enter 0. The category next comes the category 2 to enter category 1. And then the 3 divided, the 5 states have to enter into category 2, 5 states have to enter into category 1. Done. Now we move on. I guess we confused with this. The category 5, the remaining 5 states, they have to reduce the disease burden. I'm really sorry. Let us see if we have recalled it correctly. I'm extremely sorry for that. All the category 1 have to interrupt the malaria transmission, 0 indigenous cases and deaths due to malaria. Category 2 enter category 1, category 3 enter category 2, category 3 disease burden. I'm sorry for this. Remember, in the first, by the year 2020, when you divide the 10 states into 5 and 5, the 5 states should enter category 2 and the remaining 5 should reduce the disease burden. Fine. Moving on to category by the year 2022. The category 1 and 2 should have interrupt the malaria transmission and have 0 indigenous cases. And now again the category 3 we are dividing the 5 states, okay? The 5 states of the category 3, they have to enter into category 2 and the remaining should enter into category 1. Okay, very important. Don't confuse both the things here. In the year 2020, the 10 states of category 3, when you divide them 5 and 5, the 5 states will enter into category 2 and the remaining will reduce, the disease burden will be reduced. Okay, now here in this, the category 3, 10 states, we are dividing them into 5 and 5. They will enter category 2 and the remaining 5 will enter category 1. And the disease burden, we saw here it will be 30 to 35%. Fine, done. Moving on. Next, we have 2024. Very simple. In 2024, the API should be less than 1 per 1000 population in all the states, and all the 31 states should have 0 indigenous cases and prevent the transmission of the malaria. And next 5 states in category 3 should enter into category 1. Okay, in 2024, very important about the category 3. We are focusing about category 3 in each of the slide. So here the 5 states should enter into category 1 is the target. Fine. Moving on to 2027 and 2030. This is very simple. 2027 and 2030. 2027, indigenous transmission should be interrupted and the entire country should have 0 cases and 0 deaths. Next, 2030, 0 indigenous cases and deaths for 3 consecutive years. You can see 2030, 30, 3 consecutive years. Okay, also they have to initiate the process for the certification of malaria elimination status. India should have this certificate of malaria elimination. Okay, so moving on, very important, very important, that is strategies of this malaria control program. Beginning with the overall objective of malaria elimination program is the rapid reduction of the malaria transmission in areas with a high malaria incidence. So this is area A. Okay, so let us consider this. This is area A. Area A, where malaria transmission is very high. Okay. And now we have area B, where the malaria transmission is less. So what is our strategy? The rapid reduction of the malaria transmission in areas with a high malaria incidence. So the rapid reduction, plus, okay, rapid reduction of the malaria transmission in the areas with a high malaria incidence. Interruption of malaria transmission. Here we are doing the rapid reduction. Here we are interrupting the malaria transmission in low transmission areas. Okay, interruption. Here rapid reduction. Simple guys, what is our first objective? Rapid reduction. Rapid reduction is performed in the transmission of malaria transmission in high malaria incidence areas and interruption of malaria transmission in low transmission areas. Next, prevention of re-establishment of malaria in areas where transmission is interrupted. Now, for example, there is an area where the transmission of malaria is completely interrupted. Okay. So, we have to prevent the re-establishment of malaria. Prevent the re-establishment of malaria in the areas where transmission has been interrupted. Fine. The first strategy, very clear guys. Should we just revise it? So what was the strategy we saw in the first place is reduction. So there were two areas, high incidence areas and low incidence areas. So in the areas where the high malaria incidence is found, we do the rapid reduction. Okay, rapid reduction of transmission in the areas where there is high malaria incidence. And here what do? There is interruption of malaria transmission in the low incidence areas. This was our first point. And the second point, we have to prevent the re-establishment of the malaria in the areas where the transmission is interrupted. Simple guys? Yeah, done. Next, moving on. The broad strategies of malaria elimination framework are, now they had certain broad strategies, that is early diagnosis and radical treatment. Diagnosing the cases early and providing a radical, that is prompt and complete treatment to the cases of malaria. Case-based surveillance and rapid response. And lastly, the integrated vector management. We also studied this in our first video of NVBDCP, right? National Vector-Borne Disease Control Program. We studied this vector management. How do we do? By indoor residual spraying, long-lasting insecticidal nets, insecticide-treated bed nets. So you can see here in the picture, indoor residual spraying and then insecticide-treated bed nets, or we also have long-lasting insecticidal nets. Okay, we also studied this larvivorous fish. Now for here, the broad strategies you can mention about the residual spraying and the nets. Okay, insecticidal treated bed nets and long-lasting insecticidal nets. Very simple. This point, the second point of the strategy, where there is broad strategy for the malaria elimination framework. What is that? What are the points? Let us without saying try to recall them. So what did we study guys? The first thing, we will do the early diagnosis, performing the early diagnosis and giving the prompt or correct, or we can say radical treatment. Next, case-based surveillance and rapid response to that surveillance. Next, third, the vector management, integrated vector management. Vector management by residual spraying, long-lasting insecticidal nets, and we also have insecticide-treated bed nets. Fine. Now we move on to the next point. The next strategies, they include epidemic preparedness and early response. So the high areas where the risk factors are found, so we have to be very careful about the epidemic outbreaks, just like after the calamities or heavy rainfall. If there are chances of the malaria outbreak, we have to be ready. Epidemic preparedness has to be done and early response to such a epidemic. Next, monitoring and evaluation, coordination and partnership. We are coordinating and having partnership with the like for example, we can consider the public sectors having a partnership with the private sectors, the non-governmental organizations, NGOs, so the international health agencies. So having a partnership with the other intersectorial coordination and partnership. Behavior change communication. So we are having an interaction with the community or the population and bringing in the behavioral changes, that is bringing in the changes in the lifestyle or changes in their attitude towards their problem. And the community mobilization, if there are high risk areas and they are epidemic prone, so we have to perform the mobilization of the community from such areas. Program planning and management, so we should have a program which is pre-planned and also the management should be proper. So guys, what are the other strategies? Epidemic preparedness and the rapid response. After the epidemic, you can correlate, okay? Now just for example, let us consider there was an epidemic outbreak. We have to rapidly give a rapid response to that epidemic. Followed by the epidemic, we need to monitor and evaluate the cases, and then we alone can't do it, so we want the coordination and partnership with others. And also along with the partnership, we have to bring in the behavior change in the people, because unless they don't change, we cannot help them that effectively. And the community's mobilization. And lastly, to perform all this, we need to have a program which is planned and management should be done. So clear guys, how can we remember it as a story? Epidemic preparedness, we gave a rapid response to that epidemic outbreak. Then next we saw that there is monitoring and evaluation, followed by the behavior change. After monitoring and evaluating, behavior change communication, and plus we have the coordination and partnership with the other sectors, and lastly the program planning and management. Fine. Okay, let us revise it again. 4, 5, 6, 7 and 8 point, right? So in the fourth point, what do? Epidemic preparedness and giving a rapid response to such an epidemic. Next, after the epidemic preparedness, we monitor and evaluate. Monitoring and evaluation, coordination and partnership. We just can't do it alone, we just can't monitor and evaluate, we also want the other sectors to be involved. Control and coordination and partnership. Once there is coordination and partnership, we have all the human source. Then we will go to the behavior change communication and the community's mobilization, and the lastly, that is planning and management. I hope the strategies are very clear guys. From the start, okay, the strategies, the quick revision of strategies. The first place, we have to reduce the malaria transmission where there is high malaria incidence. We should interrupt the malaria transmission in low transmission areas. We should prevent the re-establishment of malarias in the areas where the transmission is interrupted. Okay. Next, we saw the broad strategies. They were early diagnosis and treatment, case-based surveillance and rapid response, and the vector management by residual spraying, long-lasting insecticidal nets and insecticide-treated bed nets. Followed by the other points. So we saw that epidemic preparedness, rapid response, monitoring, evaluation, coordination, partnership, behavior change communication and community mobilization, program planning and management. So here we have completely studied and memorized all the strategies. So I hope everything is clear so far. Now we are moving on to the last part, that is key intervention. So we know each of the category. We have categories, right? First let us revise our categories and then move on to the key intervention. So what are the categories? Let us just, okay, fine. So we have category 3, which is intensified control phase, where the API will be more than or equal to 1. Fine. The intensified, what is it? The intensified control phase. Okay, in this intensified control phase, where the API is more than 1 and 10 states are falling under this category, let us see what intervention can be done. What are the key interventions? Category 3 is also known as intensified control phase, where the API will be more than or equal to 1. So we can massively scaling up of the existing disease management, and we can bring in the preventive approaches. Massive scaling up of all the existing disease management and prevention approach. Okay, and we do this management and prevention. What is our aim for the management and prevention? So that the significant reduction in the prevalence and incidence of malaria and the associated deaths to the malaria can be done. So we want to bring in a significant reduction in the old as well as the new cases of malaria. We have to bring in the reduction in the malarial cases, and we have to prevent the deaths which are occurring due to malaria. Since the API is more than 1 here or equal to 1, we have to focus on, it is a high incidence areas, right? So rapid reduction, we have to focus in the reduction. So you can see scaling up of the disease and management and preventive approach. This management and preventive approach is for what? We are rapid reduction of the malarial cases and the deaths which are occurring due to malaria. Next, screening of all the fevers which are suspected for malaria. So we have to screen all the cases which are suspecting for malaria. Tailored interventions for the areas as per malaria epidemiology and risk of transmission. So we need to bring in the interventions as per the malarial epidemiology in that area, and based on the risk of transmission we need to bring in the tailored interventions. Special interventions in the high risk areas. Who are the high risk areas? They are the tribal people, conflicted area, and hard to reach areas. So the high hilly regions or something like that. So the tribal populations, the population which is residing in the conflict affected areas, or hard to reach areas, in such groups we need to bring in a special intervention. Mobile clinics on the fixed days in these areas. So hard to reach areas, for example a very high hilly area, we should have a mobile clinic. Okay, we need to have a mobile clinic on a fixed day in such areas. Timely referral and treatment of the malarial cases. So we know we need to refer the case. If in case it has come in PHC or in Anganwadi, you detected a case of malaria, then we need to refer it to the CHC or the urban hospitals and institutions. So we see that we need to have the timely referral and treatment should be given for the severe malaria cases. Robust supply chain management system. So we need to give an optimum level of supply of the drugs, and the supply chain management, okay, has to be of the robust is nothing but optimum supply. Optimum level of surveillance have to be performed. Equipping all health institutions with microscopy, RDTs, injectable artemisinin, and then artemisinin, and for the treatment of severe malaria. So we see that the RDTs, that is rapid diagnostic test, and the microscopic facilities have to be given in this high risk areas. So we also have to give them the anti-malarial drugs, that is artemisinin derivatives. Fine. Guys, I hope the category 3 interventions are quite familiar. So now we can just quickly brush through. What are those? Scaling up of the diseases, management and preventive approach, so that we get we can reduce the deaths and the cases of the malaria, and screening the fevers which are suspected for malaria, and bringing in the interventions as per the epidemiology, as per the risk of transmission in high risk areas, in conflicted areas, in the tribals, hard to reach areas, which are nothing but the high risk areas. We have to bring in the special interventions, and also the mobile clinics for them, referral system, and treatment of the severe malaria cases should be done promptly. And then the robust supply chain management should be maintained, and optimum level of surveillance, and all the health institutions we should provide them with microscopy, rapid diagnostic tests, and the drugs for the treatment of the malaria. Next, moving on to the key interventions for the category 2. What is that? This states the category 2 are those who are having an the API less than 1 in the states, but there are certain districts which are having API more than 1. It is a pre-elimination phase where API is less than 1 in certain states, but few districts will have API more than 1. So they are in the pre-elimination. The states or union territories in pre-elimination phase, they are very close to entering the elimination phase. We know most of the states are having API less than 1. Just because of certain districts here and there, they are not into the elimination. So they are very close to entering the category 1. They are very close to entering the elimination phase. Therefore, malaria elimination interventions will be introduced with main focus on setting up an elimination surveillance system. Our main focus is to set up an elimination surveillance system and initiating elimination phase activities. We are mostly, since they are very close to elimination phase, our activities are such that they are initiating elimination phase activities in the districts where API is less than 1 per 1000 population at risk per year. So we saw that API will be less than 1 in these areas. In such areas, we have to initiate the elimination phase. Clear, guys? Very important and very simple. Here we see it is just very close to entering. The first point, it is very close to entering the category 1 or the elimination phase. So we have to focus completely on the malaria elimination and set up such a surveillance system, and we should initiate the elimination phase activities. Mostly the elimination phase activities will be initiated in the districts where API is less than 1 per 1000 population. Yeah. Moving on, the efforts will be directed at interrupting the local transmission. Mandatory notification of each case of malaria from the private sector, the government sector, and other health facilities should be given. The notification should be given if any malaria case comes up. They need to notify. Okay, they need to notify us. Next, adequate case-based surveillance and complete case management across the country to handle each case of the malaria. Investigation and classification of all the foci of malaria. Okay, guys? So this is these are the other interventions. So we see that this is the category 1. The category 1, because they are already having an API less than 1. So all the efforts in the category 1 will be directed at interrupting the local transmission. I need to add the title here. That is category 1, which is in the elimination phase where API in all the states and union territories is less than 1. So since they are in the elimination phase, so any case comes up, any case of malaria is seen in private, public sector, government sector, we need to notify it. Next, the case-based surveillance should be adequate, and we have to give a complete case management across the country so that each and every single case of the malaria can be handled, and the investigation and the classification of all the foci of the malaria. Okay. How can we do this foci of the malaria? How can we investigate and classify the foci of the malaria? By performing these investigations, field visits, and we need to classify all these foci of malaria, and the total coverage of the foci can be given by the vector control measures. Okay, you can see in the next slide, a total coverage of the foci will be given by the vector control measures. We saw the various vector control measures by doing this residual spraying, providing bed nets. So now we are in the elimination phase. So any disease comes up, we notify it. We perform this case-based surveillance, and we investigate all the cases, classify the foci of malaria, performing a strict total coverage of this vector control measure, because the vector needs to be controlled so that the transmission can be interrupted. So the strict total coverage of the foci. We need to detect the cases early, provide the prompt treatment in all the cases of malaria, and any suspected fever comes up, we need to treat it. And the implementation of interventions so that the effective screening, management and prevention of malaria is done. So the interventions for effective screening, management and prevention of malaria, we are ensuring the quality medicines and diagnosis. We are giving quality medicine. Now here it is in the elimination phase. So for it to enter into the category 0, where there is no zero indigenous cases, we are trying hard that giving the quality medicines and diagnosis. During investigation of the suspected cases of malaria, they are to be screened, and then we need to screen the neighbors, colleagues, relatives, etc. If there is a suspected case of the malaria, you need to screen even the neighbors, his relatives, and also if he's working, his colleagues also need to be screened, so that we don't want to miss any case of malaria. We need to do the earliest detection, give the quality treatment, notify the disease, and screen the other individuals who are related to the patient. And next, surveillance of special groups, like we saw the high risk group, like the migrant population, the population residing in industrial areas also need to be covered. Okay, the surveillance of the special groups like migrant population and populations residing in the urban areas. So these were the interventions for category 1. And last, other 2 points are setting up the national level reference laboratory. We need to set up the national level reference laboratories, and establishment of state and national level malaria elimination database have to be made operational. So we need to establish this database and make it operational. Fine. So this was about the key interventions for category 3, 2 and 1. So let us just brush through. Category 3, we did the scaling up of the diseases, we screened the fevers, and intervention was done based on the epidemiology. High risk groups, the intervention was done, mobile clinics were given for this high risk group, and referral treatment and treatment was given for the malaria cases, robust supply chain treatment. And then we have optimum level of surveillance, and all the health institutions will be provided with a microscopy, and providing them rapid diagnostic test and the drugs for the treatment of the malaria. This was in the category 3. Next, we saw category 2. They are very close to entering the elimination phase. Very close. So we need to set up elimination surveillance. Very close to elimination, right? So the elimination surveillance system has to be set up, and we have to initiate the elimination phase activities. The activities should also be elimination phase activities where the API is less than 1 per 1000 population. Next, moving on, we have category 1. In the category 1, the main focus is on interrupting the transmission because it is in the elimination phase. So we need to notify any case comes up. We need to provide the case-based surveillance and management of the cases across the country, investigation and classification of the foci of malaria, and providing a strong, controlled, strict coverage of foci by the vector control measures, detect the cases, give early treatment. After detecting one case of the malaria, also detect the neighbors, colleagues, relatives, so that you don't miss out on any case. In case you find out, notify the case, and then ensure once the case is detected, you need to perform the proper diagnosis, give quality medicines to them. Okay, and effective screening, management and prevention of malaria is done, and also the surveillance is performed on the migrant population and people residing in the industrial areas. And we are setting up national level laboratories and state and national level malaria elimination database. Okay, one is laboratory and the other one is database has been made operational. Now lastly, we are moving on to the category 0 and coming to the end of the topic malaria. The category 0, we need to detect any reintroduced cases of malaria. So now the category 0, what did we study? zero indigenous cases. There are no cases of malaria in that area. Zero indigenous cases or zero deaths which are occurring due to malaria. No case of malaria. No person is suffering with malaria and no deaths are occurring due to malaria. So, in such a case, we need to detect if there is any reintroduced case of malaria in the community. So, we know there is no malaria. We need to check if there is any reintroduction. Okay, reintroduction needs to be checked. Determine the underlying cause of the resumed local transmission. If the transmission has occurred in that area, find out what is the cause for the resumed transmission of the malaria. Apply the rapid curative and preventive measure to eliminate that case and then prevent the reintroduction, re-establishment of malaria transmission, maintain a malaria free status in these areas. Very simple. Category 0, guys. Category 0, no cases are there. So make sure there is no reintroduction. Maintain the malaria free status. Detect any reintroduction. Prevent first. Okay, let us keep it like this. We will first prevent the reintroduction and maintain this malaria free status in the area. If in case a introduction occurs, we need to detect it and find out the underlying cause of the resumed transmission, and lastly provide a cure and preventive measures have to be done. What is it? We need to prevent the transmission, maintain the malaria free area. Okay. If in case the reintroduction of the malaria occurs, we need to determine the underlying cause and give the rapid curative treatment and also provide the preventive measures. Okay, this was about the category 0. Thank you. With this, we come to an end of the topic malaria. I hope all the things are clear. If you have any doubts, put it in the comment section. And if you like the video, hit the like button and subscribe.